Good morning, everyone, and welcome to today's webinar, Caring for Transgender Individuals at Risk for Thrombosis. My name is Kim Roque, and I'm the Manager of Education for the Foundation for Women and Girls with Blood Disorders. Next slide. Our mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To that end, we aim to provide education to healthcare providers on medical consequences and unique issues for women and girls with blood disorders. Next slide. I'm joined today by our two faculty members, Dr. Joshua Safer, who is the Executive Director for Center for Transgender Medicine and Surgery and a Professor of Medicine at the Icahn School of Medicine at Mount Sinai in New York, and Dr. Barbara Kunkel, Founding Board Member of the Foundation for Women and Girls with Blood Disorders and the Associate Chief Scientific Officer and Associate Director at the Washington Center for Bleeding Disorders and the Director of Hemostasis, Platelet Immunology, and Genomics Laboratory at Bloodworks Northwest in Seattle. She is also Professor of Medicine and Hematology at the University of Washington in Seattle. Next slide. Our disclosures for today's webinar are listed on the screen for your review. Next slide. To ensure the best sound quality during the webinar, all attendees will be muted and in listen-only mode. However, you will have the opportunity to participate in a question and answer session with the faculty at the end of the webinar. You may submit your questions during or after the presentation portion of the webinar via the chat box in your GoToWebinar control panel found on the right-hand side of your screen, and we will address those during the Q&A session at the end of today's presentation. Next slide. Before we begin, we have a question for the audience. We'd like to take a quick poll to see how many people are joining us with others. Please take a moment to answer the question on your screen. Okay, we'll give you just a few more seconds. Please go ahead and take that poll if you haven't already. Great, thank you so much. Close the poll. Great. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we are recording the program and it will be archived on our website. I would now like to turn the call over to Dr. Barbara Kunkel. Next slide.
Good morning, everyone, and thank you for joining. It is my pleasure to present a few slides. I will just briefly review what we know about exogenous hormones and cisgender women and talk about contraceptives and hormone replacement. And then I will turn the microphone over to Dr. Safer, who will discuss approaches to care and hormonal approaches in trans men and trans women. Next slide. We will not be discussing therapy for hormone-responsive cancer, which is another use of exogenous hormones. Next slide. So just as we think about thrombosis, it's important to remember that venous thrombosis, and it's also true for arterial thrombosis, but shown here are rates of venous thrombosis by age. And venous thrombosis is a disease of aging, and although we see it in young people, it markedly increases as both men and women age, and we have to take that into consideration when we are considering the risk of using exogenous hormones. Next slide. So this is a table that just reviews what we know about venous thrombosis risk and contraceptive use. And listed are a number of oral contraceptives, beginning with those that have earlier progestins added, and then third generation. And the risk with really particularly with levonorgestrel, you'll see that the risk in the normal population is about 2- to 4-fold, And then with later developed progestins, it actually is about double that. And that initially was a surprise because we thought the risk of thrombosis was dependent on estrogens alone, but we now know that the progestin can really protect from the effect of the estrogen, and so there is variation. The transdermal patch and vaginal ring carry an even higher risk, and that's likely due to increased absorption. And this is in contrast to what we see with hormone replacement therapy, which is a much lower dose estrogen. And then progesterone-only contraceptives overall do not carry an increased risk of thrombosis. The MEGA study, which was a large case control study in the Netherlands, did find an increased risk with the injectable progestin, but that has not been replicated in other studies, and it may relate to the population, since that was an observational study, the population for which it was prescribed. There is definitely no increased risk with the progesterone-coated IUD. Next slide. And there was a recent study that confirmed that the lowest dose estrogen plus levonorgestrel carried the lowest risk of pulmonary embolism in the overall population. Next slide. Next slide, yeah. So what about just some key, and what about women who are at higher risk of thrombosis? So the risk is highest in all women in the first 3 months after initiation, including those who have a higher risk of thrombosis. But the risk continues with long-term use. Thrombophilic women, they have a higher risk if there are symptomatic family members. So there is a difference if the individual was just for some reason tested and found to have an underlying thrombophilia versus having a family history. Absolute numbers, I think, are most useful when we're talking to our patients and in people who are heterozygous for factor V Leiden or for the prothrombin variant. The risk is about 0.2 to 0.5% per year, and those are real numbers that we can use. And as I said, it's higher if there's a positive family history, and even if there's no lab abnormality, there's about a 2-fold increased risk with 1 first-degree relative and a 4-fold increased risk with greater than 1 first-degree relative. Next slide. So what about hormone replacement therapy? So we have limited the indications for hormone replacement therapy, but there are women with menopausal, with vasomotor symptoms that are severe enough that it's really interfering with their lives, and they may need short-term hormone replacement therapy. Next slide. So the oral estrogen replacement does carry a risk of thrombosis, and it's been shown that this risk is significantly higher in obese women. But with estrogen alone in replacement, which would be given to a woman without a uterus, there is no apparent increased risk with transdermal estrogen, and now we have a number of studies supporting that. There was some question in terms of the progestogen, and it appears that transdermal estrogen with micronized progesterone it does not carry an increased risk, or if it does, it is very small. There are some studies out of France where this has been used in women with a history of a DVT without increased risk. I think we need more data in this area, but I think it's certainly an option for women who have a remote history of a precipitated DVT, something like that, where they need systemic estrogen replacement short term. Next slide. But one option that really can provide women relief is local treatment for vaginal or urinary symptoms. And there's no increased risk of thrombosis with vaginal tablets and rings. This is because there's really no systemic estrogen absorption. Overall, vaginal creams have been documented to be safe, and the recent analysis of the Women's Health Initiative data showed that in women who use this, there was no increased risk of coronary artery disease, stroke, or venous thrombosis. There are some reports of increased absorption with the cream, and it's likely due to over-application, and so this can be approached with education, and there's a new intravaginal DHEA approved treatment for dyspareunia associated with menopausal symptoms, which does not carry not thought to carry an increased risk of thrombosis. So now I will turn the webinar over to Dr. Safer.
Great, thank you very much. That's a lovely introduction. Thank you all for listening. For my talk, what I really want to do is quickly give an overview of transgender medicine and our current approaches to treatment, which gives us an opportunity to think about how we might strategize to minimize VTE risk. The outline is going to be really first just a little bit of an overview of the sea change in approach to care, and then we'll continue on with the current strategies specifically. So vis-a-vis the sea change, the important thing to observe is that when we are considering the potential factors determining gender identity in the past, environment, or this being a societal construct, or it being a passive response to anatomy, were thought to be the explanation and the basis for various interventions, with being transgender then thought to be a mental health concern with a mental health solution. But there has been a real paradigm shift, recognizing that gender identity has a substantial biological component that cannot be changed, and that changes our approach, therefore, entirely. Our evidence that there is this biological underpinning, it doesn't give us much in the way of mechanism, but there are kind of four broad categories of evidence. The first being historical attempts to manipulate gender identity, primarily in people who are termed intersex or DSD. And a second category of data relates to twin studies, where simply identical twins have a greater likelihood of both being transgender than other sibling pairs. A specific example, kind of the most illustrative case out there for children with DSD or intersex conditions was one from the New England Journal from about 15 years ago by Reiner and Gerhardt, where they looked at what ended up being 16 individuals who were XY, for whom at the time, because gender identity was thought to not be biological, to create female genitalia for these individuals and raise them as girls. By the time the study was completed, however, all of the children who knew their medical history were identifying as boys, opposite of the program, and in great surprise considering what was dogma at the time. On the subject of twin studies, really the only literature out there is a survey of case reports where it's observed that fraternal twins, where one is trans, and have a case report in the literature, the twin is not trans, where with transgender individuals who are twin pairs, when their twin is an identical twin, about 40% of the time the twin is also trans. It's important for us to remind our non-medical colleagues that identical twins are not really identical, and so this 40% concordance rate actually is quite high. For example, type 1 diabetes has about a 50% concordance rate. Other Evidence categories include in utero androgen exposure data, simply that there is more male gender identity among XX, that is female chromosome individuals, with virilizing congenital adrenal hyperplasia and exposure to androgen in utero. Most of them have female gender identity, to be clear, but the minority of male gender identity is a much larger fraction than we see in the general population of XX individuals. And the last category are attempts to find brain anatomy associations with gender identity, which has been done to a modest extent, but those are the weakest data. Bottom line, though, is that we have this expectation, even though absent mechanism, that there is this biological underpinning. That all said, when we're thinking about strategy, we have to recognize several inputs. One of them is that presentation of transgender individuals in adulthood or late adolescence is more the norm than the exception still. And that's the larger number of transgender individuals we're seeing presenting. We don't have a test, we don't have a scan, and so it's by self-report. We're talking, when we survey people, that maybe approximately 1 in 200 or 0.6% of the population would be transgender. So as people get more language, we're seeing more of them. And whether this later presentation is the result of their ability to have the language or even understand what is going on with their body, or whether it's conforming in an unsafe environment, is not known. Another element that we have to consider when we're considering the strategy for treatment for transgender individuals is fertility, which is addressed in an ad hoc fashion at this point, but we recognize that hormonal interventions are going to compromise fertility substantially, and of course some of the surgeries are going to completely destroy fertility. With regard to, again, strategy, other inputs are and the observation that where people think about testosterone versus estrogen kind of as opposites, that's really not the case. It's really bringing testosterone up and down in individuals, and then recognizing too testosterone impact on people's appearance, where many transgender individuals are trying to shift their appearance to match gender identity. So this picture that I have in front of you is a picture of identical twins who, again, are not literally identical, but very similar, where one of them is transgender. That is, the one on your left is transgender. And this photograph was taken immediately prior to their 15th birthday, where they both are XY, but the girl received GnRH agonists, that is puberty blockers, and and simply remains on her linear progression. And really what I want to point to here is the boy, the non-transgender one, the cisgender one, because look at the impact of testosterone maybe for about a year or so on his body. You're expecting the hair above his lip, but of course there are midline structure changes as well, like the growth in the size of the nose or the larynx where the soft tissues are growing, and you can imagine that his voice must be dropping as well. The SCM muscles on the side of his neck are visibly larger, and this is a kid who is not known to be weightlifting or anything at the time, more of a bookworm at the time this picture was taken. That's really just testosterone effect. And then, like I was alluding to a little bit before, important to recognize that whereas estrogen levels, to the degree that estradiol, which is what we measure as a reasonable surrogate, are not that different between men and women. That is, maybe a little bit lower, statistically significantly lower in men, but with substantial overlap in the ranges, and unclear that it's clinically different. But testosterone is probably tenfold greater among men. So when we actually think about our strategies then, for little kids, we do nothing. The hormones are not different. We think that gender identity has a biological element that cannot be manipulated. So kids who, what is called socially transition, where that is go to school wearing a different haircut or different clothes, are not going to commit themselves to be transgender. People can feel quite safe letting kids do whatever they want, because that's completely reversible. And then, because we're waiting to find out if how people express their gender identity and are not always trusting, of children, because we know that some children who say they are trans end up not wanting treatment later as adults, that when these kids hit puberty, we use GnRH agonists like we do for precocious puberty to delay puberty. And then the fear there, this slide is just, I'll just buzz through this pretty quickly. The fear there is that when you have any period where you would have imagined people would be exposed to sex steroids, but then you block those sex steroids, there might be some harm to bone. The only data out there are this Dutch study where essentially on your far left you see these kids at baseline. Then they the middle bars are what happened to bone. These are z-scores, so it's relative to peers. It's not that they actually went down, it's just that they fell behind their peers with regard to bone density. So that's what's represented in the middle there. And then when they actually received sex steroids, the key element is that in this particular study, they didn't necessarily return to baseline. They were still a little bit behind their peers. The study, they used low doses of hormones. The kids were a little on the old side when they did all of this. There are some issues, but the bottom line is it's not reassuring, but it is really still a concern that there might be a bone harm. And just the net of that is that with kids, when kids have a well-established transgender identity, we probably want to actually begin sex steroids and protect those bones, and not delay that beyond what's necessary to understand what's really going on with that individual. For men, strategy is pretty straightforward. We use testosterone supplementation, just like for any man whose testosterone level is too low. I'm a little bit agnostic in terms of what form of testosterone is given. There are injectables and topicals that are the most popular and are the main ones that are available in the United States. There are, I think enough said about that for the moment, because we want to switch gears a little bit. The only pitfall with regard to androgens is that androgens stimulate erythropoiesis, and so like for any individuals for whom we're giving testosterone, we do want to make sure hematocrit stays in a safe range. The guidelines say below 50%, purpose being to create a little bit of a cushion there under the numbers where thrombotic events have been observed related to high hematocrit. A fear that this testosterone will be converted to estrogen does not seem founded, however. Now, switching gears, I think, to really where we want to be focusing for most of the rest of the conversation today. With transgender women, we're blocking that androgen, and we're trying to not simply have them have no sex steroids. So we're actually using, as our primary agent to lower testosterone levels, estrogens. Feeding back centrally, lowering the testosterone into the female range in order to remove those androgen-like effects. And then also the estrogen serves that dual purpose of being available as a bone protective agent. But the caution, and this is what we're discussing today, is the fear of thrombotic events. So specifically here, just demonstrating estrogens feeding back negatively being perhaps the primary purpose for which we're using them. So I just want to go through a little bit of the data as it relates to transgender individuals. A paper from last summer in Annals of Internal Medicine was just basically a data mining operation in the electronic medical record of the Kaiser Permanente organization out in California. And what was observed is that identifying maybe about 5,000 or so total transgender individuals and just shy of 100,000 cisgender individuals, and comparing relative risk of thrombotic events, that there were maybe 3 to 4, depending upon how you look at the controls, excess events per 1,000 people among the transgender individuals after about 2 years, and maybe 14 to 16 per 1,000 individuals in terms of extra events out at about 8 years, looking like there really is this risk to some degree. Even with the numbers as large as they appear, it still was impossible to control for other confounders, whether it be other behaviors, lack of access to care, and things like that. But does seem consistent with our fears. Other data we have out there, I guess this is a little bit tying in with what you just heard from Dr. Kunkel. This is actually not transgender specific. This is a British Medical Journal from early 2019. And again, kind of some of that same summary of data where there seems to simply be a dose response effect among the different kinds of estrogens in terms of their risks. And I think what I want to say, actually, I want to say one more thing with regard to these sorts of studies, is it's unclear to me that other relative thrombogenic character that are assigned to some of these treatments are independent or relative or really relate to just a dose response connection. So for example, topical transdermal estradiols are supposed to be safer, but I don't think we have good enough assays of estrogen in order to know if that isn't actually just another dose response effect where, because not much is absorbed potentially, the people are simply getting lower doses. Similarly, for many of these agents, adding a progestin, or the progestins that we tend to use like medroxyprogesterone, substantially increases risk. But is that an extra estrogen-like aspect of the progestin, or is it specific to the progestin? And I guess I would just say we don't know. Maybe this will all be reduced to a dose effect kind of situation, depending upon the type of estrogen. And then one other important thing to consider with regard to transgender women in treatment is recognizing what the overall absolute risk is. It may be the case that transgender women or women using estrogens have some increased risk, and we can detect it if our studies are large enough and well enough designed. But this is just a prospective look at just shy of 700 transgender women over about 2 years with oral estradiol, which is the most common estrogen given to transgender women, where they only had one recorded DVT event that wasn't even life-threatening. And so when advising patients, it is important to not focus too much on the estrogens. One issue with regard to transgender care is because of this concern, some people erroneously over-associate the estrogen VTE risk and neglect interventions that are more important. So, for example, an individual going to surgery may have her estrogen stopped, where really the appropriate intervention is whatever the correct DVT prophylaxis for the surgery and the duration of the surgery, et cetera, is really what's warranted. Or I've seen patients, transgender women, who've had, let's say, a pulmonary embolism sent to me with their estrogen discontinued, as if that solved the problem. But in fact, I don't even know that it was significantly contributing, and an appropriate anticoagulation regimen would have been the more reasonable thing to do, and maybe just leave the estrogen on board. In terms of our treatment, just a couple of other things to be clear on on kind of what we know. So ethinyl estradiol, which is the estrogen in oral birth control, seems to be the most thrombogenic. That was the estrogen used in relatively high doses in the Netherlands for transgender women, with the resulting maybe 5% incidence of thrombotic events, really quite significant. When they switched in the Netherlands to estradiol, 17-beta estradiol, in 2004, they stopped being able to detect an increased rate of thrombotic event above the background Dutch population. And another point from this slide are just to look at the doses a little bit for transgender women, what's required to actually suppress testosterone into the male range. maybe 2 to 6 milligrams of 17-beta estradiol, or maybe even more, maybe 8 or 10, and parallel kinds of doses if conjugated estrogens are being used, 2.5, 7.5, and then mind you that when we're using conjugated estrogens, we're a little fuzzy on our dosing because we're really only measuring estradiol as kind of a surrogate for how much we're giving them. Injectables, just be aware that they're out there. They're not super, I find them a little bit problematic because if it's all a dose response concern with regard to thrombosis risk, then we are potentially giving people more overall product when they have basically a peak and then a trough. The area under the curve is a net of more estrogen exogenously. And then the transdermals are out there as well, although especially for younger women, because not as much product actually gets across the skin, I think we sometimes have trouble actually getting the testosterone levels down with this this route of administration. Bottom line, though, is when we think about our health concerns for hormones, it's really hypogonadism, that is low, having no sex steroids and the osteoporosis risk, and then maybe some superphysiologic concern with testosterone, that erythrocytosis reality, which only in a rare individual leads to any increased harm that we can identify, and the thrombosis risk, of course, that we've been talking about, and not much else. What we're doing then when we're treating transgender people in terms of actual care out there in the community these days are following, let's say for transmasculine, which is what's up on your slide right now, testosterone, and then a hematocrit for the concern that I've outlined already, and then for primary care providers, recognizing that we have a very surgery focused conversation in society about transgender people. Actual transgender people don't have as much surgery as people realize, and so for transgender guys who often still have uterus and ovaries, appropriate monitoring needs to be done, like let's say pap smears or what would be appropriate to screen the cervix, and breast monitoring if there is tissue, and bone if there were long periods without hormones at all. And for the transgender women who are having a trans-feminizing regimen, we're following testosterone because, again, that's actually what we're manipulating, trying to get that down into the female range. Because of the fear of thrombosis, we use adjunct therapies to lower the testosterone and maybe decrease the dose of estrogen that we can give. You can use GnRH agonists. The Europeans use progestins, although perhaps those increase thrombosis risk. And here in the United States, we actually use spironolactone, an old potassium-sparing blood pressure agent, and therefore common in terms of what we're monitoring is actually potassium, as I've indicated on this slide here, along with other levels that might be more related to just good primary care. And then the other big thing that's important when we're caring for transgender women is same thing as the guys, recognizing the tissues they have. Transgender women probably have more surgery than transgender men, but even when they have a vaginoplasty, it's important to recognize that nobody actually goes into the abdomen and scoops out the prostate, so that's there and needs to be monitored, and then bone health concerns relating to periods off sex steroids. I want to talk about the surgery just very, very quickly here, just again, because if we're thinking about strategy, I think we need to recognize what body parts people really tend to have. So your transmasculine or female to male individuals almost invariably have chest reconstruction to have a male chest and not to have breast tissue there. They can have a hysterectomy and oophorectomy, but that's only done actually in a minority. And the genital surgeries have concerns, especially relating to our inability to do well with urethral tissue, and so there are many complications with these surgeries, and therefore really only single-digit percentages of transgender men even have those surgeries. And then the key point with regard to transgender women is really that although the vaginoplasties work well for transgender women, priorities in terms of aligning body with gender identity are broader, I think, than many people recognize. It's not really all about the genitals. There is no the transgender surgery. And indeed, we see almost as much facial feminization surgery, especially for older transgender women, where they've been exposed to a lot of androgen and they have all those facial features I demonstrated on the earlier slide with the twins. And though, that's what they really need in order to have their body aligned with their gender identity, let's say when they're out in public, and frankly, even from a safety perspective, if you think about it, rather than having genital manipulations, which is more between them and their significant others and may be a lower priority. There's similar logic with regard to breast augmentation, which is much more commonly done. Maybe a small majority of transgender women look for some breast augmentation, even though there's substantial and sometimes excellent breast development just from hormones alone. And then the genital surgery for transgender women works pretty well, the vaginoplasties. And so in the hands of good surgeons, these can be popular surgeries, but again, they are not the be-all and the end-all. I think that's my last slide, and so let me then open things up. Thank you all for your attention.
Terrific. Thank you, both Dr. Safer and Dr. Kunkel, for a very informative presentation, as well as sharing your expertise and experience with the group. At this time, we will proceed with the question and answer portion of our program. As a reminder, you may submit questions via the question and answer box in your GoToWebinar control panel. And it looks like we are already having questions come in, so thank you very much. So as I read our first question aloud, I believe this question is for Dr. Kunkel. If you had a transgender woman with a history of unprovoked VTE that resulted in pulmonary embolism, would you prescribe her estrogen?
So I think I'll have Dr. Safer answer this also. So I think one has to look at it individually. Certainly if we have someone who has an unprecipitated pulmonary embolism, then they're at high risk of recurrence. And so I would ask him, in his experience, I would think there would be situations where long-term anticoagulation, we know the practice, if we have a cisgender woman who has a hormone-related thrombosis, the practice in the U.S. is often to stop the oral contraceptive immediately, kind of, because thinking that caused the thrombosis. And the practice by many, particularly in Europe, is to continue the contraceptive while they're on anticoagulation to give them birth control so they don't get pregnant, particularly on anticoagulation. And what we've learned from that is that that combination is safe. And those women do, from the data we have, do not have recurrent thrombosis. So that gives us confidence that we could use anticoagulation to allow hormonal treatment. We also know with studies in terms of long-term prevention with rivaroxaban and apixaban, again, this is not in the presence of hormones, but that you can use effective low doses that have very low bleeding risk. So I would, in a situation where hormone replacement is really important, I would consider those options to allow hormone replacement. That's off my top of my head, but in just thinking through these things in a few clinical situations. So Dr. Safer, do you have a comment on that?
Yeah, thank you. I think the comment for when we think about it in terms of transgender women specifically has a couple of elements. First, like I've alluded to, and Dr. Kunkel points out, for cisgender women, not to overly ascribe harm to the estrogen and then neglect other elements. So it's interesting with regard to birth control. where the European view is maybe protecting against pregnancy would be the higher priority than worrying about the relatively modest contribution to thrombotic events from estrogens, and that's with ethinyl estradiol, which is the most thrombogenic of estrogens as far as we know. And for transgender women, where we're not even using ethinyl estradiol, we're using less thrombogenic estrogens, that risk could be less yet. And it might be a little bit of a red herring to chase after that when really anticoagulation is the requirement. And then when that anticoagulation is instituted, then whatever minimal risk might be assigned to the estrogen might be completely protected against, at least to the degree that the anticoagulation is protecting in general. This has definitely been an area of evolution in the field. If you look at older guidelines, things have been very conservative, and so people ascribe huge risk to estrogens initially, and even as we've tried to back away, there are caveats and parentheses and expressions of caution, but I think as we move forward, we just gain confidence as we observe that the risk might be detectable in very large studies, but it seems to be overstated still.
Thank you both for the very informative comments. We have a number of questions coming in, so thank you all from the audience. I believe this question is again for both of you. With secondary polycythemia, which is less than 50% as suggested due to testosterone, would you recommend therapy such as phlebotomy versus the lower dose versus other?
Yeah, this is an important question, and it's kind of the same situation as we observe with regard to the thrombotic events in estrogens, which is erroneously assigning harm to the hormone and not to something else. So androgens, when taken in appropriate doses, and certainly men who have endogenous androgen levels that are about the same, is not really associated with causing a polycythemic situation as much as unmasking something that probably has another explanation, whether it be smoking or altitude or some underlying concern. And whatever that is, that's what needs to be addressed. I have to sometimes explain to some of my medical colleagues that I don't treat an elevated hematocrit situation by causing another disease and, let's say, rendering a man hypogonadal by decreasing his dose and putting him at risk for bone harm and whatever other harm you might have by being hypogonadal. The intervention is like this question suggests, is going to be phlebotomy, removing whatever the other concerns are if they exist, like sleep apnea or smoking, and then phlebotomy if it's a polycythemia vera or an idiopathic elevation.
Wonderful. Thanks very much. We have another question coming in. Which patients should be started on thromboprophylaxis before starting hormone therapy? And again, Dr. Safer, I think that's for you.
As a rough rule, we don't have people where adding estrogen treatment is the last straw that results in our adding an anticoagulation agent. It's more a matter of somebody for whom that would be indicated potentially anyway. What sometimes happens, though, is that somebody for whom this might be a reasonable consideration, taking an aspirin, depending upon the circumstance and the data, might be a reasonable thing, but they're really only coming to medical attention because this is a transgender woman showing up for estrogen therapy. But like I said, I don't think we have any data that that's the one thing in some algorithm that's going to result in starting therapy. I can say for psychological reasons, and I'm not sure it's whose psychology, whether it's the doctor or the patient, there are definitely people who maybe they're at some borderline, but they don't stratify into a risk category that you would actually use any treatment. Then it's a transgender woman who wants to begin estrogens, and then because there's some little anxiety that anticoagulation is begun, I just have to caution that we don't want to make the same error that we've alluded to now twice with the previous questions of assuming a harm, treating with an anticoagulation therapy, exposing this person to a bleeding risk, and really for something which is more a fear than an unknown risk.
Thank you. Dr. Conkle, what do you think about thrombosis risk for depot or implantable progesterone?
Yes, I alluded to that in my talk, that the MEGA study showed an increased risk of thrombosis, and this is in an outpatient population who had a thrombosis in a large anticoagulation program. And they found some increased risk. This was not found with oral progestin, and certainly not with the progesterone-coated IUD. The Norwegian data did not support that increased risk. These are observational studies, and so they could be influenced by the population for which this is prescribed, because in some areas it's not prescribed very frequently, and so may be prescribed for individuals who are not reliable and or are other kind of social determinants, and so that could affect their underlying risk of thrombosis. And so I think that we have to take into consideration there may be some increased risk, but it's very low, and that in the decision of the best, usually the decision of the best contraceptive is going to overweigh that concern. If one has a person who has had recurrent venous, idiopathic, unprecipitated venous thrombosis, a really high-risk individual, antiphospholipid syndrome, one could think that a great approach, if possible, is using a progesterone-coated IUD that we know absolutely carries no increased risk. But generally, a very modest increased risk would not be of concern to me in terms of prescribing this to an individual if it was the best contraceptive.
Terrific, thank you. Dr. Safer, what do you consider the risk for testosterone replacement for transgender men? There's data from HST for cisgender men and Klinefelter men that there's a thrombosis risk with testosterone replacement as well.
So the harm risk for transgender men with testosterone is really whatever might result from that stimulation of erythrocytosis, and when we look at larger samples of transgender men, we have difficulty actually finding increased events in cross-sectional studies. So I'd say it's a little out there. There have been a few papers where people kind of hand wave and say that there might be increased cardiac risk. It depends compared to what, of course. So if the comparison is cisgender men, then we're not seeing it. Yeah, I think I'll just leave it at that. There's a relatively large, fraught meta-analysis that's of great controversy in the androgen world in general, thinking that there might be some cardiac risk for exogenous androgens for older men, but studies that were included there are also not sufficiently controlled to be sure there. Maybe there's a small increased risk, is what I tell my men who are getting androgens as they age. And so if you're going to take it assuming those studies are accurate, and there's some small risk out there, but they're hardly conclusive.
Thank you. Dr. Safer, do trans women undergo natural menopause, or do they need other medication?
Interesting question. So transgender women have testes, which are there unless they are removed surgically. And so the pattern with those testes would be presumed to follow that of cisgender men. And therefore, as they reach menopausal age, where we're giving them estrogens for the purpose of suppressing the testosterone, we do need to consider what we want to do with that treatment going forward. Even a transgender woman who's actually had testes removed because she's had a vaginoplasty or just simply had the testes removed, and we're giving her replacement estrogens, then we're in complete control because we're giving her estrogens exogenously, and we might want to shift the dose following a typical menopausal pattern at the appropriate ages.
Thank you. The next question may be for both of you, and this involves a case. We have a 19-year-old female transitioning to male who also has sickle cell disease. No history of DVT. Would you recommend DVT prophylaxis given the theoretical compound thrombophilia of the hormones and sickle cell disease?
Let me comment on the trans side of it, and then Dr. Kunkel maybe can add in. So this is a transgender guy getting testosterone, if I'm understanding the question, where I don't think we think there is a there's a thrombosis concern. So I think I would simply give the treatment. The only question might be route of administration using injectables, but I don't know of any data that that's harmful per se. And so it might be just simply, though, a practical considerations along those kinds of lines, but not a harm from the androgen itself or a DVT risk from the androgen itself.
Yeah, I don't know of literature on testosterone use in patients with sickle cell disease. I would not, this is not data-based, obviously, worry as much about venous thrombosis as if it would perhaps affect like crises or that, and I don't know. So I think it would be probably, I don't see a reason that you would say, oh, we can't do this, but obviously watching closely the pattern of disease of the sickle cell disease.
Thank you. With a trans adolescent girl with underlying thrombophilia, would you recommend lifelong anticoagulation?
I'll start on that one. I think it's important to understand what the thrombophilia is. We know that with the milder, and whether she's had a history of thrombosis. If she was diagnosed by family studies and has a mild thrombophilia, we know that even with oral contraceptives, which has been pointed out are more thrombogenic, the risk is very low. And so I think we can't lump all of, I would look at a woman with antiphospholipid syndrome and recurrent thrombosis very, very, very differently than someone with a genetic mild thrombophilia who's never had a thrombosis. And so I think in those individuals, the risk, and Dr. Safer can comment on this, I think of replacement, there's likely not something to do except for the person to be aware of symptoms of thrombosis with replacement estrogen or with estrogen treatment versus someone who's at much higher risk, where you may have to consider whether any increase in risk would pose a problem. And that's a small group of women that we're talking about in that group. Dr. Safer, do you want to comment?
Yeah, my only thought is I'd be very deferential to the approach for an equivalent cisgender woman or girl, and really leave it at that. I would not defer the transgender treatment. I would follow the transgender treatment, and then simply, and then simply have the treatment, any protective prophylactic treatment be, like I said, following a kind of a cisgender protocol. My fear being that we would risk committing making an error of commission rather than omission, where we're instituting a treatment to protect against a risk that's not that significant.
Thank you. I believe we have time for one or two more questions, so let me choose wisely. In choosing an oral contraceptive, would DOAC be an appropriate choice versus warfarin?
So this, I assume this question is if someone, so in terms of oral contraceptives, there usually is not a reason that you would anticoagulate someone so they could be on an oral contraceptive. You may anticoagulate them when they are, during their treatment time initially, and then transition them to, say, a progesterone-coated IUD. And so in individuals who, for whatever reason, need a treatment that increases their risk of thrombosis and they're at very high risk of recurrence, then I think one, and there are no data on this, can consider co-administration of anticoagulation longer term, and we have no data to say what's the right approach in that setting.
Thank you. All right, let's take one more question. How would you use an IUD in a male wanting to transition to female?
In a male who transition to female, you would not. I guess the tissue that is a neovagina. If somebody's had a vaginoplasty, it has different tissue, and so I don't think we would assume similar absorptive capacity there. If you're talking about like a hormone-eluting one, and there wouldn't be a purpose for another one because there's not a pregnancy concern, of course.
Thank you. And we have time for one more question, and then if we don't get to your question today, we will have the speakers answer those and send responses directly to you. So our last question is, rivaroxaban, perhaps more than the other NOACs, has been associated with increased menstrual bleeding. Is there any data in trans men?
The short answer is there are no data. This is way beyond anything that's been investigated.
Great. All right. Well, wonderful. Thank you all so much for sharing, again, your experience and expertise with our group. That is all the time we have for questions. As a reminder, you'll be able to review this webinar for your reference or share today's proceedings with your colleagues by visiting fwgbd.org and accessing this webinar under the Archived Webinar section. For those who may have additional questions on this material following today's program, we encourage you to visit our Ask the Expert feature on our website and submit your question online for the review. We encourage you also to register for our next webinar on connective tissue disorders and EDS coming up on November 15th at 12 p.m. Eastern Time. We're delighted to have Drs. Pamela Trepane and Sarah O'Brien serving as faculty for the event. Next slide. We thank you all for your attendance today and look forward to future participation in Foundation programs. And again, special thanks to our two speakers today, Dr. Safer and Dr. Conkle. Bye-bye.